Hello, everyone, and welcome to the first live session inaugurating the third ECERPH conference dedicated to public health issues in the context of the COVID-19 pandemic. This conference has been organized by MDPI and the International Journal of Environmental Research and Public Health. I would like to take this chance to thank our chair and all the people from the conference committee for making this conference possible, and all the participants for joining us today. During the next 2 weeks, you will be able to assist to several live sessions with excellent speakers and have the opportunity to read and comment all the author submissions presented for the conference. So please look at our webpage during this time for more updates and register for free for the following live sessions. I would like to remind everyone that this webinar is being recorded and that we will also have a YouTube live streaming. The recording will be posted on the conference webpage for everyone to watch it as soon as possible, and I will be sharing the YouTube link through the chat in a few moments. Now I will present our chair, that is Professor Øyvind Odland. Øyvind is a professor of global health at the Norwegian University of Science and Technology and a specialist in environmental medicine and epidemiology. He has worked on mother-child programs in more than 20 countries, these days mostly focused on the Arctic, South Asia, and Africa. He has published over 200 peer-reviewed papers and is now involved in a new study on the impact of the COVID-19 pandemic on healthcare workers, the healthcare system, and the general population in Southern Africa. Thank you very much for accepting to participate in this session. The microphone is yours, and everyone enjoy.
Thank you very much. It's a pleasure to be here. This is actually the third time I'm a part of the organizing committee of an electronic conference for the journal, and it has been really an exponential development of this. And of course, when we came to our very stressful situation now globally with the COVID-19, our tool is a fantastic instrument to meet people, even if we are not physically together. So this is really a new way we develop teaching, we develop conferences, we develop research activities. I'm actually now involved in a quite big application process in the EU system where we have 20 partners. We can even meet together sitting at my kitchen table. So it's quite a new challenge and new opportunities as well. What I really want to emphasize for this conference, of course, COVID-19 is a global pandemic. It's so important, but it's also so important not to forget other challenges. We still have HIV, we still have tuberculosis, we have cancer, we have the lifestyle issues, and we have so many challenges we really need to address. And that is why I'm so pleased to give you our first presenter today. And he is Dr. Masoud Dara. He's a physician and global and public health specialist. He says he is from Belgium. Today he is sitting in Minsk in Belarus. And he is mostly working on the programs for the WHO on tuberculosis, HIV, and viral hepatitis. So, and also other things. So I think I don't like to have long introductions talks. So now I really want to give the word to Masoud, please.
Thank you very much, Professor Odland. John, highly appreciated the introduction. And greetings to all the colleagues and who have joined across the globe for this interactive, hopefully, session. I will have a presentation. I would like to make sure that colleagues also take time to reflect and also share their experiences. That's very important. So actually the title of my talk is about tuberculosis and HIV response during the COVID-19 pandemic. I would like to actually give you a short overview of where we are with tuberculosis and HIV burden at the global level and what are the key challenges that we have so far before the pandemic and also what is the impact of pandemic on the TB HIV response, and also the opportunities and also next steps. So HIV, as you know, is been around as a exposure that we consider has been coming from the history that we know. It's been from the first case, which was in a country which is called Democratic Republic of Congo now. The first case was from 1952. Retrospectively, we understood that was HIV-1 virus. It was largely unknown till 1970s, and the first time was in 1983, which was discovered as a virus causing AIDS. In 1987, WHO, World Health Organization, launched the global program on AIDS. And in 1994, the heads of the states and the presidents and prime ministers got together during the UN General Assembly that for the first time ever, any disease was discussed at the level of heads of states, and they considered the response to HIV as a priority, and consequently in 1994, the UN AIDS was established, which is the UN United Nations joint program to respond to HIV/AIDS. Since the beginning of the epidemic, actually, we have 76 million people infected, and 33 million people, unfortunately, have lost their lives. That's very important to consider the numbers because that shows the impact. And as you know, particularly Southern Africa has been highly affected, but almost all the regions of the world have been seeing the rise of the HIV. But then with a good response, we see that we have been able to control since 2019, in fact, in the year of 2019, 38 million people were with HIV living, more than half of them women. So there's a vulnerability among the women and the young girls, which is important to consider. And 1.8 million children with less than 14 years old have been living with HIV. Unfortunately, only 26 million people of them were on the treatment, antivirals. And unfortunately, 690,000 people have died due to the AIDS. So we had, as I mentioned, some good progress, which has been declining of the HIV new infection by 23% since 2010. And mortality rate has been also decreasing, declining by 39% if you compare with the 2010. However, some regions, particularly Eastern Europe, Central Asia, the HIV new infection has been on the rise until recently. Key populations are playing an important role, and who are the key populations? These are the commercial sex workers, men having sex with men, as well as also the migrants and the drug users. And these are the people who have a higher risk of getting the infection, and their sexual partners together. Globally, 62% of all HIV new infections are among the key populations. And if you see in Eastern Europe, Central Asia, up to 99% of new infections are happening among the key populations. So that's very important for us to have the concept of leaving no one behind, but also address the needs of key population. And as you know, tuberculosis is a leading cause of death among the people living with HIV. And that's the reason that when you talk about HIV, you should also talk about TB and the other way around. We don't have vaccine, no cure, but also prophylactic treatment has been available, which is very effective. We have been also seeing a lot of progress in terms of testing and quality treatment, which has led to the healthy life. And at these days, as you know, people can live with HIV, lead a healthy life when they're on treatment and even not transmit to others. On TB, we have, as you know, it's been emerged since 70,000 years ago, and has also in 1882 has been discovered, Mycobacterium tuberculosis, but 1/4 of the world population is infected. There's a difference between infection and the disease. So people, once they have vulnerability, they can actually develop the disease. 10 million people fell ill, which is 56% men. So men are more commonly vulnerable. And 90% of them are in 30 countries. And 2/3 of them are in these 8 countries which are named here. And unfortunately, 1.2 million people died of TB in 2019. So many in the whole world, actually, the target has not been reached in terms of reducing the incidence and mortality of 20% and 35%. So much more work needs to be done. And what is important also that 3 million people have been missed. So the health system could not find these patients and been not diagnosed timely. And that's basically transmission that's happening among them. If you look at the work and achievements, more than 60 million deaths have been averted by effective tuberculosis treatment. And we talk about the key population in HIV, and in the TB, we talk about the risk factors and social determinants. There's poverty, HIV, undernutrition, overcrowding, migration, and diabetes, smoking, among others. And also, there's a vaccine, but it's not efficient in adults. And it's mainly for children. There's drug-resistant TB and co-infections also posing challenges. Now, what are the common challenges between the TB and HIV? We have not been on track to achieve the targets of 2020. You know, we have the 2030 as a target to achieve the United Nations Sustainable Development Goal. And we have not been on track overall. Only 10 years left to achieve the targets that we want. So late diagnosis, even in Europe, we have more than half of the HIV, people with HIV are detected, diagnosed at the latest stage. This is this for HIV. And also we have many people with TB also missed in terms of diagnosis. Services are not adapted to people's needs because these are the special population that you need to provide the services which is flexible and adaptable to their needs. It's not in many settings. And migrants in many settings are left behind. Stigma, discrimination of these diseases. These are also diseases which are often associated with this discrimination. And quality care has not been equitable access. Commitment, global commitment have not been enough resources despite the Global Fund, despite all the World Bank and all the funding has been increased, but it's still a lack of funding. And financial burden on patients. These are diseases that is just causing poverty, and people are living in the poverty because of the treatments and diagnosis. And very important in terms of research and innovation is being very, very slow. And HIV has been much better, but on TB almost we don't have new approaches and new treatment, point of care testing and so forth. Now, what are the key challenges on pandemic? Lockdowns. The first thing that we saw in the first wave that countries were putting lockdowns or restricting movements. Of course, when it's a restriction of movement, people will not be able to come to the healthcare facilities to get their treatment or not to be detected on time. So that's a major challenge that we had so far. And also in terms of factories to produce medicines or diagnostics, there have been also challenges. And also once we have them, how you have to procure them and distribute them on time when there's a limitation of the transport or cross-border exchange. And obviously, pandemic is very important. We are talking about 19 million people up to now having COVID-19. About 2 million people have lost their lives, unfortunately. So the health system or ministries of health, they prioritize everything they can to address the TB, to address the COVID-19. But on the other hand, this can lead to deprioritizing other areas like tuberculosis, HIV, hepatitis, and other health programs, which also was mentioned by Professor Odland. So healthcare staff are repurposed, often infectious diseases specialists among TB specialists or HIV specialists. They are working on COVID-19, so the experts are less available. Facilities are restructured, inpatient facilities or even outpatient are used for COVID-19. And in some cases, for example, on TB, the gene expert or molecular technology is also being used for detection of COVID-19. And as I mentioned, funding is an issue. And a bit of other areas that we need to also consider is unemployment because of people may lose their job or poor nutrition and stress, which can also lead to even more tuberculosis. Last but not least, mental health, which to the pandemic and also aging and non-communicable diseases can lead to increase of the rates. Now, in a nutshell, also what we have been, our headquarters already got the information from comparing what has been immediate impact, and based on a survey done in the countries, we look at the multi-month dispensation of the antiretrovirals, availability of the medicines, antiretrovirals, and any disruptions there's there, and even services and there is. So this basically shows the challenges that we have in different regions. In African region, it's the Mediterranean, it's European and others, and a number of basically the countries that they have reported the risk that we had among the countries. And then here they also see that the situation in terms of the 68 countries even reported the risk of the availability of medicines, because that's very bad, because once people are not on treatment or the medicines are not provided in multi-months, that means that they have to come every month to get their medicines. That can pose a problem because of their health and also ongoing transmission. And particularly in terms of services, testing has been, the largest number of countries have mentioned about the testing being disrupted. And that's very, very important to try to catch up. And then in terms of in our region, actually we also did in European region, we look at some of the examples, what's happening, particularly in some countries that we have data. Testing has been really, really reduced, up to 80% in some countries. And also the preventive measures have been also interrupted, and the key population have been reported to have a higher stigma and discrimination. So far, the treatment has not been interrupted in European region, but follow-up of the patients has been also a challenge. So on tuberculosis, there's another survey which was done by Global Fund. You can see the result of it. And then you can see that 78% of the global TB programs have been reporting that they have disruption to services. In the services of tuberculosis has been disrupted. And also in terms of the 20% having high rate of the disruptions. Desktop TB partnership colleagues did a very good modeling, including the countries with a high burden of TB, high burden of HIV, high burden of drug resistant, and they came with this, and that only 3 months of the lockdown, and also 10 months to try to be protected, getting back to the services, is going to lead to 6 million more people dying of tuberculosis. And that's actually really, the challenge that we have. And the incidence can go back to what we had in the past, which was 2015. So that's in summary basically. Longer you have the lockdowns and the restrictions, you have higher number of TB deaths because people are not detected timely. And if they're not detected timely, they may develop severe forms of it, let alone the transmission among their families and close ones. So the WHO has already issued guidance, which is basically helping the countries to make sure that essential health services, including TB and HIV, are prioritized in the context of the pandemic, and then recommends that some kind of practical actions, like dual track services, like prioritizing the diagnostic and so forth, and also having indicators to have an overview of the how the services are provided. This is the guideline. I put a link there. In our European region, the Regional Collaborating Committee, which includes more than 40 NGOs and other actors, they also issued a call for action, which is make sure that human rights, equity, and dignity is pursued during the COVID-19 response, and also mitigate the risk and ensure programmatic approach to essential services, but also making sure that the health and safety of frontline and community workers are protected. I would like to basically, in line with what was discussed, but what Jan, to highlight the importance of digital health solution, that is important, and you need to prioritize, fast track. So particularly a tool is called video supported treatment, needs to be prioritized. You don't need to have the staff, healthcare patients to come always to healthcare facilities. Why not to make sure that they can connect, they can get the support they need during the pandemic using the digital solutions. And also for the telehealth, for example, consultation of the health clinicians, and as well as the e-learning and the e-conference that we have now today. So what are the opportunities, the next step? And need to have the health system which are strong and resilient health system. Now, health system has been very much prioritized. So we need to grasp it as an opportunity to build all the strengths of the health system to address the pandemic, essential services, but also other risks that they may have. We need to also address the risk factors and social determinants, non-communicable diseases, as well as communicable diseases need to be both of them prioritized because they are interacting with each other. We need to also strengthen the psychosocial supports and intersectoral collaboration to address TB, HIV, particularly during the pandemic, and international collaboration, which is crucial in order to address the challenges across the globe. Digital health solution that I mentioned, and for example, online appointment arrangement, instead of patients going there and waiting in the waiting room to wait for the tests. Why not to make sure an appointment is arranged in advance to decrease the waiting time? People-centered care and more outpatient home-based care needs to be prioritized. Infection prevention control for all the services need to be prioritized, but also capitalizing on what's happening on research and development on COVID-19. Take the example of vaccines, whether they could be some helpful through breaks, which can also the other diseases can benefit from. This is basically an acknowledgement to all my colleagues who also contributed to presentations, member state partners, as well as all the colleagues from our country and regional office and headquarters. Thank you very much for your attention.
So thank you very much, Dr. Masoud. We are in a very good timing here, so I hope that you have some important questions from the audience. If there are any chat questions or in the Q&A, I think you should take them immediately if you want to chat with the people listening to us.
I see actually Professor Mitra has asked a very good question in terms of BCG vaccination in the prevention of TB among HIV patients. As obviously, I think it's going to be, as you know, BCG is not, we should not give BCG to people who have a weak immune system. But on the other hand, there's another potential that actually was discussed earlier, and that's the role of BCG vaccination in terms of potential protection against COVID-19. I think that's what was probably is being referred to here. And that's been ongoing research, and I do not know the outcome of that research. It was a multi-country study to look at whether people who have BCG vaccinated, they have better protection against COVID-19, yes or no. And there was some speculation that BCG can provide non-specific immune response, which can partly protect. Now, having said that, we have also already very effective vaccines for COVID-19. I think at this point of time, despite all disappointment that we had with the treatment for COVID-19, which, as you know, antivirals were not showing any meaningful impact to decrease mortality among severe cases. We have already vaccines, so which is, there are several of them, including the mRNA and adenovirus types. And we hope that these vaccines need to be disseminated as soon as possible. But of course, because of production needs to be scaled up and so on. So that's basically what I would say in terms of the role of BCG vaccination in the COVID-19 response. Over.
Can I just add one other quite serious question for me, is that you show that the mortality for TB and all how we can prevent and solve TB challenges now is set back to maybe 10 years or so. How can we address these issues?
Absolutely. I think that's a very, very acute challenge, Professor Odland, as you rightly said, and we are very much concerned. TB is a disease of poverty, and millions of people are affected, and the numbers going up. So in terms of mortality, which is acute, I think the first and most important element is to countries to do fast tracking diagnostic services. And that's what, for example, in Belarus with our colleagues, we want to do, is to have a intensified case finding. Contact tracing has been placed, but we should see people who are symptomatic, and there's also an opportunity to do both testing for COVID-19 as well as TB. So people are coming for testing, why not to check, have you cough, is it productive cough? So this could be early tuberculosis, you have been in contact, you have family that had already had TB. So intensified case finding with using also all the facilities that are available, but also community mobilization and talking to people. Because I think that's very important. I think when you open TV or radio, the only thing you hear is COVID-19. It means that we have to also communicate to the population. If you've done the COVID-19 test and is negative, but it's still coughing, maybe you have TB. So why not to think about that one? So one part is population specific. The second, very important to have the healthcare facilities and healthcare staff fully aware of the importance, and the ministries of health to allocate adequate resources to make sure we are catching up with the decreased detection. In some countries, up to 50% reduction of the TB case detection. And of course, that leads to to the fact that, people come with a late and late stage of the disease. Need to be intensify our efforts there. Over.
But the follow-up question will, of course, be then, what happens with the migration here now? What happens with the multi-resistance that we know for TB? What will happen in the years to come?
Multi-resistant tuberculosis, particularly in some regions in Eastern Europe, is high. And of course, that's also quite challenging, because what we did a study, actually 50% decrease, in addition to the detection, almost 50% decrease in enrollment on treatment. So it means that people are not on treatment. So they're very important to make sure that the treatment is in place. But the cause of the drug-resistant tuberculosis is being also inadequate treatment. So if people do the self-treatment because they don't come to the facilities, and we're talking about global area, when people can feel sick or already think they have a TB and go and get the self-treatment, that can also increase the rate of drug resistance. So what we need to be done is to make sure that healthcare facilities are adapting to the services, providing online consultation and also physical examination of patients when needed to detect the patients. Appropriate, adequate full treatment needs to be in place. But one example I can bring in is also operational research that my colleagues are in Europe are leading in several countries to have a shorter treatment for MDR-TB. 2 years treatment with injectables is very, very cumbersome. On their operational research, our colleagues are looking at alternatives, which is a shorter and non-injectable. You don't need injectables, so you don't need to, for injection, you have to come to facility, but for oral treatment, you can also get the home treatment. And now we are scaling up this research to have a more effective treatment and more people-friendly, patient-friendly. Migration is another challenge, and actually, particularly people who don't have access to undocumented, they don't have access to services, they will be also left behind. Actually, for HIV, there was a group of people who were locked in other countries, and they could not get treatment because they were supposed to go back to home country and they could not go. And thanks to the involvement of some of the NGOs, managed to procure medicines and bring them to them. So I think that needs to be kind of community engagement, and NGOs need to be well activated because they have proximity to population. Could be Red Cross, could be Red Crescent, where they know who are these people and making sure the migrants are also not left behind during the pandemic. Over.
Well, just to follow up my last comment to you, this is so important to address because now everybody, we are closed down in different regions, in different countries. Then comes all our old bureaucratic systems coming in even to prevent treatment. Is there any way we can solve that in the near future?
Yes, I think what we need to also look is good practices. I think some of the countries have been doing very good, and we are collecting all those good practices because we need to look at reflecting the first wave of the COVID-19, and also in the meantime, how countries managed it. So practically, we need to look at good examples, but also talk to health authorities. And I think that's what we need to address, that not to forget about all these efforts, because that's investments of many, many years, and all the progress can be challenged and be lost if for 1 year or 1.5 years, we are not putting still adequate efforts to catch up with the challenge.
You see, my last comment before, I think there are some others as well, but I've been working quite a few years in Southern Africa. And what happens now if you are a South African and live in South Africa, then you get the health service. But if you are an immigrant from Zimbabwe or Malawi, you don't get the same treatment. You're not offered the same quality. So how can we solve this?
Yes, and I think one thing that we can, particularly for tuberculosis, and we can also refer to is the United Nations high-level commitment. 2 years ago, all the head of states got together, they made a declaration. We need to see more resources. I think we need to hold them accountable and make sure that the funding coming to COVID-19 is not leading to decrease of funding for other priorities. And that's the first thing that we need to consider. And also basically bring all the experts around the globe. I saw our colleagues mentioning about Bangladesh. Yes, there are also national experts and international experts across the globe. We need to collaborate and coordinate, share the good practices and experiences, and move forward by basically building on the investment case. Because as a politicians, you should also tell, like, you invest in this amount of money on these resources, this is what's going to be, let's say, the benefit of it for the population, not only having less people dying or suffering, but also having less number of infectious diseases that they need to be addressed in the future. Over.
So I think you have maybe answered already from Amal Mitra, yes, but there is another from Udhav here about the shortage of healthcare workers. Can you look at that?
Yes, yes, that's a global problem. What we basically, there should be, the solution, of course, is that it should be multifaceted, and it's not specific to TB HIV, it's also for many other areas that we have an inadequate number of healthcare workers. I think the first and most important one is to protect healthcare workers. As you know, many countries, they want to applaud healthcare workers, and that's very good, it's emotional, it's very nice, but this should be translated to action. So it means that healthcare staff should have been attracted to the work. So now we have personal protective equipment for that's important, but also not only providing them with the respirators, but also fit testing, also other elements, should be whole package. So not only the respirators, but also the environmental protection, but also most important administratively, how to decrease the workload or distribute the workload or patient concentration in certain facilities. And then very important also in terms of retaining them. So making sure that they're encouraged to continue the work, and also attracting more younger generation to the working on healthcare as a healthcare staff. And I think that should be comprehensive policies from the countries to make sure that this kind of small rise, sometimes they give salaries, more salaries, is not only short term for the pandemic, but should be also longer term. So make sure that you get the best of the society coming there to work for the health systems. That's important to consider. And also some encouragement in terms of career development. So people should also be able to engage in the research, and not everyone, but those who have interest in it, and also all the package that we can provide to make sure that the healthcare staff, they're feeling continuously to feel proud of what they're doing and continue to better health for the people. Over.
Thank you very much. I cannot see any other at the moment, but Dr. Masoud, I hope you will join us for the next half hour. So I think when people think they can come back with a chat or a Q&A question here later.
With pleasure.
So thank you very much so far.
Thank you very much.
So maybe we can switch to my own presentation. Let me see if I can see here, this one. So what I want to share with you, there's some thoughts about what happens with the COVID-19 and the pregnancy situation. I know there will be some very interesting presentations later in our conference. I'm not sure if it was the third or second day, but we will find out. And I really hope that all of you will follow these days when we have the regular webinars, and also look at what is presented with posters and videos and so on. So we have a lot of presentations during the coming weeks. But I want to share some thoughts about COVID-19 and pregnancy. As was told before, I'm an epidemiologist, environmental medicine doctor, but also I started my career as a clinician with a specialty in obstetrics and gynecology. So I've spent my time at the hospital, at the delivery ward. I've done my 1,000 cesarean, and also delivered all around the world. So one of my big issues at the moment, that is to provide pregnancy care and education in Southern Africa. And I've also been engaged with my Russian colleagues for environmental medicine and also pregnancy care for many, many years. So it's been quite an interesting travel. And I'm so happy I'm still on the travel. So we will continue our good work. So Just as to show the headline here, being pregnant as a teenager is a serious matter, but it's also quite serious when you get the COVID-19. I have to take you back to the very beginning. This is the most vulnerable and crucial time of life. This is when you are, it's a conception. And I regard as an environmental medical doctor also that maybe the most vulnerable time for environmental exposure, that is before you are born. And of course, this is the crucial part of life when the sperm is losing his tail, the ovary is locked immediately. Behind this poor guy losing his tail, there are 50 million dead sperms who are quite disappointed. This is a fantastic picture, electronic picture made by a Swedish photographer called Lennart Nilsson. He has taken a lot of fantastic pictures inside the uterus during the pregnancy development through the different trimesters. And also what we say in environmental medicine, we call it exposure windows. In these exposure windows, there are different external factors. Those are working on this. So placental transfer and exposure windows. Just to repeat, for some of you, this is familiar. For some of you it's more new. But the placenta develops from day 6 to 7 after conception. Before that, it's the yolk sac and the different other ways to get the nutrition to the embryo. And the placenta functions both as a facilitator and barrier. If you come in contact with drugs, if you come in contact with viruses, with bacteria, parasites, it all depends on the time in pregnancy and how the placenta barrier is developed. So toxic elements might cross the placenta, and nutrients should in principle cross. For some, the transportation is intact. For some, it's partly consumed by the barrier. And there are also some elements, those are metabolized, and some are even not transported. In epidemiology, we can find nice ways to look at this barrier for substances, even if we don't need to have fancy lab work on this here. And that has to do with another thing, that placenta is so extremely different between the species. Even between mammals, it's very different. You cannot extrapolate findings from a vista rat to the human because the placenta barrier is totally different. And there are some certain elements you should never forget. This is placenta from a boy I delivered in week 34 in my home hospital. The placenta is totally destroyed. It's abruptio, it's calcification, it's small. The baby, I'm sure he lost a lot of his IQ points before he was delivered. And that has to do with smoking. This lady, she smoked 30 cigarettes per day. And of course, people don't really understand the effect it can have, how that can damage the whole pregnancy environment, all the way from the water to the placenta to all kinds of nutrition that this baby has lost. Another important issue that is infections, and that's where we are now when we can talk about the COVID-19 also. That is a virus, and a virus is, but certain types of viruses are so different also. So I'll come back to that. But you know, rubella has been a big threat to babies if you get it before the week 12. If you get it in the first trimester, it can make severe damage and malformations. And there are certain medicines, like some antibiotics, that can make damage in week 8 or 9 or so. And then we have all the pollutants. But don't forget that when with infections, they also change, like parasites and a bigger bacteria, they can go through later in pregnancy. Because, as I told you, the barrier is changing. For the pollutants, it's also important to know the times in pregnancy and how the barrier acts. This is how the placenta deals with the element cadmium. Cadmium is a very toxic element. It comes very much through the tobacco smoking. But if you do a simple study with cord blood, with a comparable mother's blood, you can see even if you have quite high levels of cadmium in the maternal blood, you don't get so much over. And you get, there's a complete barrier. This left down there, the blue one, that is an artifact. Because in general, the barrier is protecting the baby against the cadmium. But there is something else coming into this here. If the mother is smoking 30, 40 per day, if you have a very heavy exposure and the concentration in the mother goes up to like 40, 50 nanomole per liter, there is something we call a threshold. And the threshold is such that the barrier cannot stand it anymore. And then the baby gets this very toxic element. So the nature is trying to be perfect. But in real life, nothing is perfect. So that's how the cadmium is behaving in the placenta. But if you look at the lead, maternal lead levels, it's almost a free passage to the placenta. And these persistent organic pollutants also, they are mostly bound to lipids. And of course, there is a very, very good transfer of lipids through the barrier. And that's why you get a lot of them over the placenta. These are very simple examples of what we see. But as for lead, this is quite serious because we have many times in history tried to establish like a basic threshold level for health effects. But as we can see from our latest epidemiologic studies and follow up in our cohorts, we can see that lead can have an impact on brain development, even at very low doses. So this threshold level to say that above or below 20 nanogram or so, it's getting out of the toxicology now also, because you can see that even in very small concentrations, they can have a damaging effect on brain development. So the only way to solve these problems is to keep the exposure as low as possible. And also we know that placenta is trying to help us. That was like a general introduction. So now I will come into something about what do we know about pregnancy and the coronavirus. Pregnant women might be at increased risk of a more serious course of certain viral infections in general. For example, in the case of influenza. We do not yet know if this is also the case for diseases caused by coronavirus. But one thing I can observe as a clinician, I still do my clinic 1 day per week, and I see a lot of pregnant women. And it's almost been the influenza epidemic that we normally see through winter time in Norway. It's been almost absent this year. Is it only that we have started to wash our hands, to keep a distance to the neighbor, or has to do with that the coronavirus is imposing and suppressing? We don't know. But we have quite a lot of good epidemiologic studies going on now. What I want to tell you today is the knowledge of today. I don't want to say anything just to say that this is so terrible and so on. We have to adapt to what is happening, and we have to get babies. We have to get safe pregnancy. So far, based on the available information, pregnant women seems to tolerate the coronavirus well. I talk about the physically part of it. But pregnant women are not especially vulnerable to a serious cause of the disease caused by the COVID-19. So these are actually good news, or maybe good. The status is good at the moment. But we have a lot of studies now ongoing with possible complications to be explored. Does the COVID reduce gestational age? Does it damage any placenta? Does it do dysmature or small for gestational age? Are we delivering prematurely? Do we get increased incidence of preeclampsia? Is the frequency of cesarean sections affected by this? Maybe I will turn it totally around. Maybe we have a mental health problem, that we are scared. Maybe this the mental situation can also induce premature deliveries, very serious depression of pregnant ladies because they are scared. We should not underemphasize that. There are so many sides of being pregnant. It is the physical part. You get 10 times more of some hormones than you usually do. And of course, that makes you also mentally and psychologically vulnerable for what is happening. So I think most of what I say today should just make at least some pregnant women to relax. But even so, this is not to say we should not be careful, because you can get all the other problems with the COVID-19. But as my good colleague Masoud said to you in the other lecture, he talked about how important it is to take care of other sides of health now. So one of my biggest challenges is now to give a safe pregnancy and safe delivery for the pregnant women living in this serious pandemic COVID-19 time. To prevent infection, you should follow the same advice as the general population. We should not give a specific advice. You should not stay inside and just stay in a long 9 months quarantine. That would be terrible also for the mental health of people. So what should I do if I'm pregnant and at risk? If you have a chronic disease or pregnancy complications, you should just talk to your doctor whether there is a need to take additional precautions. Of course, workplace is important. Are you working in a very vulnerable workplace? Or are you just working very nicely in a warm and nice office? You have to take this on individual basis. So together with the doctor. Remember that from the beginning, to be pregnant is not a disease. It's a very natural part of life. And we have to take it from there. But if you have some complications or other underlying diseases, you have to take special precautions. And then what do we know about the virus? Can it be transmitted from the pregnant woman to the baby prior or during birth? You know, we have certain experience in this. We know that, for instance, rubella, if you're not vaccinated, you can get it in the first trimester, making serious malformations on the baby. We know from our HIV knowledge that you can get the HIV through the birth channel, leaving a few million of children and adolescents now starting their life with HIV and have to live with it. But at the moment, we have no knowledge about the coronavirus, if it can be transmitted from the mother to the baby prior to or during birth. The study so far looks like we do not need to worry so much. The transmission via placenta has either not been detected, nor has transmission from mother to baby during the birth, the delivery process. So the routines now, they are to give birth in a normal way, but also, of course, to have special precautions if you are around with people with COVID-19. Should I follow my normal pregnancy checkup routines? Service activity for pregnancy checkup routine should be maintained as normal as usual. And of course, always discuss with your midwife or doctor when you find that you are pregnant, because we all live in almost lockdown now, and there are so serious routines for the general population that you should not take any specific precautions if you are pregnant, but be aware of what will happen. And of course, these are general things. They should be self-evident. But I have experienced ladies now who get so afraid and so depressed because they are pregnant in these serious times that even drugs, tobacco and so on can get into as a problem again. So this is very much based on where you are in the world. Like if you are in a country like in Nepal, where absolutely no pregnant women are smokers, then you go to Greenland, where maybe 50% are smokers. So whatever happens, we should try to reduce and avoid these drugs and tobacco and even alcohol. So what do you do if you suspect that you are infected or feel sick? You should just confirm the infection. You should be tested. And you should also have the regular health services coming up to discuss how it is to be carried out. So even what you go into labor, if you're not sick or infected, births will proceed as normal. Should a coronavirus infection be confirmed during or just before birth, then you will be given a separate room. Staff will be wearing protective clothing, and there is a possibility that you will also be asked to wear a face mask. This is I wrote this 2 months ago, and it's even getting more strict now, that you even have to go. You have a face mask when you go to the store. So things are changing very much with different advices, different public health strategies. So what I tell you today is not written in stone at all. It can change even in a month to go. What happens if you get a fantastic vaccination now, and what will happen then after that? So we have to really stick to the health policies, the health strategies, and to take every general parts of the pregnancy seriously. And of course, some practical advices, family and friends, we want to have them there. But all visits must be assessed and arranged. And one serious problem when we started up with deliveries again after we got the COVID established, it's been quite sad for many people who even wanted their spouse or boyfriend to come there. And they were not allowed to come there, and they had to deliver alone. For us who are so old, we know that only a generation ago, the husbands or boyfriends were not allowed to go into the delivery room anyway. So this is even going back to something we had quite recently, actually. And of course, this is what I say, that it's important to facilitate the presence of a partner. But most of all, it's important to facilitate security, to make everything safe and not bring in infections into a delivery department. Because the COVID-19 is so contagious, it's so infectious that if you go in with a fresh infection, you're supposed to, it can be brought into a whole department before we have been thinking around it. Then some practical issues as well. What do we know about breastfeeding? What do you know about breastfeeding and the coronavirus? Breastfeeding is recommended even if you are infected or are sick from being affected by the virus. We have not detected coronavirus in breast milk so far. And of course, there will be follow-up studies. But breast milk, that is maybe between 80 and 90% fat. And what goes into the breast milk is mostly substances, those are lipid soluble. So relatively few infants have been reported with confirmed coronavirus. And those who have had an infection have a mild course of the disease. Remember that the way to get into the body is through the respiratory system. And also, so it's not going through blood. It's not going through breast milk. So this is what we take this very seriously. We do studies on this now, but some of the results so far, they're even showing that we should just go on with the good routines around pregnancy. So we do not yet know if the coronavirus can be transmitted. But what we do know is that breastfeeding is protecting the baby from disease after birth. It's getting all the good immune factors from mother to child and transferring antibodies. And what we know from really from the real clinical practice through changing impact from virus, from bacteria, whatever, breastfeeding is protecting. And we often see in the kindergarten that at the moment we have children who they have stopped breastfeeding, or they come in as a new child in the kindergarten. The first thing that's happening, they are really getting infections. They're getting child diseases, they're getting flu, they get really to get their own immune defense. That's what happens. And of course, those who work in these places, they get quite good immune status after a while. So if you're healthy and without systems, you should follow regular general advice of breastfeeding, meaning that we really recommend breastfeeding as the very best protection for the baby. So if you have a respiratory infection and if you're diagnosed with COVID-19, you should follow the same general advice of breastfeeding and infection prevention. And of course, keep good hand hygiene whenever you're in close contact with the baby. I have to admit, when I started my work as a surgeon, I saw some of the old professors, they did not wash their hands between two patients, where they were investigating them in the room where they were recovering from a surgical operation or so on. But some people are very difficult to convince about things. So if this pandemic can lead us just to wash our hands, really between what we do, between we have taken some other people in your hand, you have examined a patient or so on, it's fantastic progress. That's what can really prevent some of the most infectious virus and bacteria to stop to reproduce and stop to spread. And for the lady who is there, you should not touch your breast before you immediately give your breast to the baby. And you can wash with soap and water. That's always the best, soap and water. You should not do some drastic procedures with alcohol or something like that. So simple measures are the most effective. And of course, you have to avoid coughing or sneezing into your baby. But these are the same general principles. And clean your home. Didn't you do that before? Including washing, disinfection of surfaces, and door handles, mobile phones. In our time now, I think mobile phones are some of the most contagious what you can have. So door handles, but also we are knocking on these mobile phones all the time. So please take simple advice. Now I think I want to give you some real speculative thoughts about COVID-19, because I think now I have told enough from this today about the pregnancy and COVID-19, but you will have a very interesting presentation later in this conference with the latest updated scientific data. So we are running clinical studies, we are going into cohorts, and we will follow up that closely. because it's a very serious situation if COVID-19 can act almost like a rubella with the severe malformations and so on. And I can say very honestly, based on scientific facts, that that is not such case today. But of course, we will follow up that closely. But then, how is the climate change affecting the spread of vectors? That's one of the questions we really need to address now. How will climate change affect the virulence, and can certain contaminants even reduce the effect of vaccines? We have studies now in the Faroe Islands showing that certain levels of mercury, high enough, you can reduce the effect of vaccines to the regular child diseases. If that happens now also with the COVID-19, we are in a serious trouble. And one other question, we already see that the virus is mutating quite a lot. And we know that from before. This corona family of viruses, they are really eager to mutate. And the influenza virus is mutating every winter and so on. But will the increased temperature increase the mutation frequency? We don't know, but we have some places in the world where we really see some effects of the climate change now. This is a little bit on the sideline, but we know that permafrost is covering 67% of the Russian territory. And why do I show this here? This is the answer. The tundra should be like a continuous ice cap. But now the temperature warming is causing frozen permafrost to melt, and they're forming what they call in Russian thermokarst. And instead of having a continuous ice cap, we get water, we get islands, we get what will happen now? Insects are migrating with new diseases, and they are also really incubating here. They will develop new types of insects coming into the new places. We are even starting to see malaria now, and really non-tropical, even in the southern Arctic zones. And of course, that can have serious impacts of the situation of spread of all infectious diseases. So this is really a brave new world. We need to address the climate change, because the most sensitive part of nature with the temperature change, that is the virus, the bacteria, and the vectors. So that is really what is happening. So with what happens with travel in the COVID time, I think this has brought into a new perspective of our adaptation. This was the first international electronic conference we did in environmental health. It's now more than 2 years ago. And we didn't really understand at this time that this could be such an important instrument while we are not able to travel. I traveled all the world almost monthly in the years before March 2020. After that, I've been sitting in my home office and mostly done the electronic contact with my students, with my research fellows, with my institutions, and so on. So we can do it. But what we lose is the personal contact. So that's important. So we have to, in my Arctic programs, we have the Arctic dilemma, where we give the contaminants together with the best ingredients of the diet. We have in the south, we have the tropical dilemma. Should we live with DDT or should we die of malaria? These are things very much connected to this climate change and also the spread of infectious disease. If you have a good nutrition, food availability, food security, that gives you a good immune status also to resist. Because we still see that those who die of COVID-19, those are the people who are sick, disabled, who really are vulnerable from before. So this is what I want to show you from every part of the world. We want safe pregnancy. We want healthy children. This is some pictures from my Russian experience. And then we say in Norwegian, we say tusen takk. So I'm open for any questions.
What we have, it's a comment from Amal that he or she is really interested in the part of the study of lead that you showed through the placenta. He wants to know if you can share the references of those studies.
Oh, that's quite a nice question, because I don't know where to begin actually, because we have a lot of studies now on and maybe if I should type the answer. I think mostly the best way is that first of all, you could go into something called a report amap.no. That is in the website there you find several health reports from the Arctic, and we are also citing. We have reference to many studies on lead, the lead exposure, and also the latest the reports on from epidemiologic studies where we connect lead and mercury to brain development, where we do certain tests of children at different stages of life. But if you start to look at the health reports, scientific reports on this website called amap.no, that's where you can start. And I will also write down my email address, because for those who are really interested in this, please use you can send me a mail directly. It's called Odland@tnu.no. So but start with the reports of the amap.no.
Okay. So this is the time for questions. Please, anyone, feel free to use the chat or the QA box to post them. I don't know if Masoud has any question for John. Oh, you need to unmute.
Thank you. The
Perfect.
presentation was very, very comprehensive. Thank you very much, Professor Odland. I think there are lots of also unknown, but the fact that it's not like rubella, this COVID-19 is already very good news. And I think to some extent, I don't know whether you agree with that, but it's a coronavirus at the end of the day. So you would expect it more or less the same thing that is you see with other coronavirus. Of course, this is more in terms of the immune response. This is quite challenging in terms of what we see, high mortality with the cytokine storms or Kawasaki in children. I think still we need to look at all the elements, and it's good that you're doing some studies. So looking forward to some more evidence that has come. Absolutely. Thank you for a very good presentation.
Thank you. I'll just comment on this. In a way, to extract information from cohorts, that takes time. So the ongoing studies, they should be reported while we are doing it. But of course, we know a lot of general properties of the corona family, and that's of course we need to. So we know quite a lot already. But compared to like a rubella, it's very, very different.
Yeah. I have a curiosity. I don't know if you could comment something on the vaccinations, but for the pregnant ladies. I don't know if there are some people that could be concerned about having the vaccine, or if it's a proper time during the pregnancy to have it or not. I don't know if you can comment on this.
Yeah, we have absolutely no contraindications for that. I know just one case, so one person who died after vaccination. That was a very old and sick lady, and you simply cannot connect it to the vaccination. But of course, then it comes into the media, people get afraid, some people don't want the vaccination. It's more or less this discussion to and from vaccination or not, for me, that is quite a very, almost like a religious discussion. Some people, they believe, some people do not believe. For the public health issue, I really recommend everybody to be vaccinated. What do you say, Masoud?
The microphone.
Yes, absolutely. Actually, there was recently also a recommendation from SAGE that, you know, we should also include also the pregnant women. We should not really exclude them, absolutely. It's also, I will send you the link as well. If I have a possibility also to ask another question, I don't know, what do you think, John, in terms of overall the impact of COVID-19, or are we expecting more fertility rates coming higher or lower? This is very interesting actually to look at it in terms of.
Yes, you see, don't forget I've been working in Southern Africa for a while. And one of my big tasks in my pregnancy care programs, that is even to reduce unwanted pregnancies, to reduce teenage pregnancies. And then came the disastrous decision they did, like in Malawi, to close down the schools for half a year. And the end of that, I'm not sure if the impact on the spread of COVID was there, but the impact was that we have a very sad increase in teenage pregnancies. So this is even setting us back, like you talked about the TB strategies. You're set back maybe almost 10 years. We are set back in our work to prevent teenage pregnancies now for 10 years. And that's serious, because these girls, when they are pregnant, they never come back to school again. So we lose a lot of brains here. We lose a lot of good young girls who should go to school before they get pregnant. So this is one of the serious effects of the COVID as well.
We have a question in the QA box regarding the impact of the right of women to access healthcare during this COVID-19 pandemic. I don't know if you can read it.
We can read it, yes.
Yeah.
Yeah, for the climate I can do, and also Masoud can do if you want. I think this big changes of the temperatures, like it's written here, I don't think there is any correlation with the COVID-19. You see, this it's spread by the human contact, you know, and the temperature, as I've seen also in southern Malawi, in the real tropical parts, it's even been a better situation for the spread. So I'm not sure if this is scientifically proved yet, but it looks like the COVID has a better, it's thriving better in the colder climate compared to the warmer climate. But I don't know the most recent literature on this.
Okay. And well, I think that somehow you commented at some point, but also the question from UDAP, that it's regarding to the developing countries having access to the vaccine later than the other countries, which kind of impact this can.
But yes, I don't think that is quite correct, because I think at least countries like Norway, we have bought quite a lot of a number of vaccines specifically to be used in developing countries. But of course that's serious, and the biggest problem would be like if you get some corruption, if you just give money to buy something and then you lose some of the money on the road. The vaccine should be really directly given to the people working on public health. But I'm not sure if I agree that the access will be later. If so, that's serious, and that is really a political question that we have to explore. So, but the latest reports I have from my colleagues in the Norwegian development department, they say they're really controlling that the people should have equal rights to the vaccines. Thank you.
Okay.
It was actually on the chat box. I already put the link for the. This is for the Pfizer vaccine, as actually you can see. So if you want, we can read it. I think people can see it, isn't it? So we don't need to read it for them. In YouTube also channel, people can see it as well, Anne?
I will copy that
Sure.
also in the YouTube channel.
But that's, of course, as we mentioned, and this is all you know, development. So we have to look at the data. So it's very good that the Jon and also their experts are collecting the data.
Yeah.
And not leave people behind. But obviously, you know, as you see, WHO also put some restrictions there, but it's important to make sure that, you know, we don't leave people behind. Absolutely.
What I comment on that is the recommendations. They should be. It has mostly to do with the insufficient data.
Exactly.
And of course, we should not leave pregnant women in a high-risk situation where all other people are vaccinated.
Okay, we have also another question. There are some discussion on delaying the second dose of COVID-19 vaccination. They are asking how long the delay should be, or should be okay to have it.
I really don't know. Should it be 3 months or 6 months? What do you say, Masoud?
I think that this is the recommendation, which actually coming from the producer of vaccines, need to be followed up as much as possible. And there's a reason for that, because they made the trials based on those protocols. Now, having said that, if there's also the terms of, you know, so there are lots of unknowns that, you know, whether we could have a distance between the first dose and the second dose, and how long will it be? So we need to look and observe it, and I think it should be looked at there in terms of, in a documented manner, to see the impacts. Of course, the other thing is that production is so lagging behind, and the need for vaccine is so huge that maybe it's not feasible for all the countries to follow exactly the same recommended distance between first and second dose. So it's very difficult to respond to this one, but then you have to, as a public health, you need to know, okay, is it worthwhile, for example, if I give protection of 30%, 40% to more people, or whether I should go to protect 95%, you know, for the little number of people. That needs to be balanced. And then in the meantime, also collecting more data and then decide on those data as they come over.
I totally agree. And of course, we don't have enough vaccines at the moment. And that's why we have this very serious discussion about should we cover 20% or should we cover 90% and give both parts to a few people and so on. There's no simple answer on this at the moment. No.
Okay, so I'm not seeing any other question, not in the chat, not in the QA box. Do you want to comment on anything else?
Well, maybe Masoud, you want to say some final words?
But I think just want to thank all the colleagues who have joined this as we mentioned, medicine is ever-changing science. So so we have to be open to data as they come. So it's extremely important to also share your experiences with colleagues. Let's stay connected. So we cannot have, you know, the conferences where we all get together, at least for a while. But let's show that we stay connected, we share the data, we do more research. Cooperation, collaboration is really essential. And then let's build evidence. Take good care of yourself and make sure you have good physical distancing, hand hygiene, respiratory protection as well for COVID. But also let's not forget about all the other diseases and conditions, which are also important from public health point of view. Back to you, Prof. Yeah.
And thank you very much, Masoud, and also everybody who listened to us, and also for the very good questions. And of course, we have been working in the health system and in research for quite a few years, and but we are very careful because there is something we don't know, and we will get more knowledge in the time to come. And let's use this electronic conference also to ask difficult questions to the professors and presenters. Thank you very much.
Thank you very much to all of you for your participation, and all the audience, remember to join us on the following live sessions on this conference. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.